That recording. Okay, and thank you so much, everyone, for being here. I'm really excited to welcome Dr. Robert Greco today to our Insight to Impact program, doing a presentation on diagnosis. Um, Dr. Greco is Boo's brother-in-law, so I'm going to hand it over to him to do his full introduction. And sorry, Dr. Greco, you're just on mute. There we go.
Unmute.
There we go.
Thank you. Can you hear me now?
We
Okay.
can. That's perfect.
Okay. As you said, that I'm Boo's brother-in-law. My wife is her older sister, and together we share a blended family. We have 4 children, 3 girls and 1 boy, and a new addition, a new granddaughter. Anyways, as far as me, I live in Sudbury. I was a practicing radiologist up here for approximately 40 years, and I was chief of the department until I retired. And my practice consisted of general radiology, but I ended up doing a lot of interventional radiology, so I'm quite familiar with this type of patient. As far as my training goes, I commenced with an honors BSc in zoology from the University of Western Ontario. Then I moved to Toronto, where I did my medical school training at U of T. After that, I did a year of surgery as a resident, and that not being for me personality-wise, I ended up in radiology. Actually, I was quite solicited to go into radiology, and I spent, I completed my certification in radiology. I did an extra year fellowship in neuroradiology and ultrasound, and then I moved to Sudbury, which was a hometown. You never think you're going to come back, but you do end up coming back. It was a great job, and once I got used to the area again after being away for 12 years, it worked out quite well. Now, the talk we're going to talk about today is pancreatic diagnosis from an imaging point of view. And pancreas is a peculiar organ. It lies in what's called the retroperitoneal space, and that's the head and the body, and the tail lies in the intraperitoneal space. Now, these spaces are basically layers of membranes that connect the organs. The organs don't float freely in the abdomen. They're in certain compartments in the abdomen, and these compartments or connections are very important in terms of they can be pathways of metastases. So the pancreas itself has 2 functions: exocrine, which is the secretion of enzymes, and endocrine, which is the secretion of hormones like insulin. As far as pancreatic cancer goes, we can talk just generally about metastatic involvement, and there's about 4 pathways that the cancer can spread. One is through the lymphatic system, the other is through the vascular system, and the other is by the peritoneal system, which I described, and the other is contiguous, growing adjacent to adjacent organs. Now, the diagnosis of pancreas when I started was quite interesting because both ultrasound and CT we should say were in their adolescence, but they were developing very quickly. So initially, you get a patient that presents with jaundice or back pain, pretty non-specific symptoms. Okay, and basically we did what was called an upper GI series and sometimes a follow-through, along with barium enemas. And at that time, what we saw were quite late stages of pancreatic cancer, because the tumor would spread along these previous peritoneal pathways I described, I told you about earlier. One sign that we saw was the gastric pad side. So when you do a barium study in the stomach, you see a stiffening of the floor of the stomach and deformity of the floor of the stomach, and that indicates the tumor had spread upon the ligament connection between the pancreas, large bowel, and stomach. Also you could see stiffening of the superior wall of the large bowel, and that again indicates the same type of issue. Sometimes along these pathways you can see deformities of the right colon, cecum, because the tumor seeds exudates down to the cecal region. Another common sign that we saw was, compromise of the duodenum, the part that drains, part of the colon, part of the small bowel that drains from the stomach, and you saw a reverse 3 sign. It was called the reverse 3 sign of Frostberg. In any event, these were all sort of late stage changes. What came after that would be ultrasound imaging. Now, ultrasound imaging in its infancy was pretty basic, pretty linear, and with the development of multi-detector imaging with ultrasound, we got to see a more defined picture. So we're able to assess, the liver, the biliary system, the pancreas, and the spleen, and the remainder of the colon. The only caveat with ultrasound is that it's limited sometimes by bowel gas and by body habits, so the size of the patient. And but it does make, in the ideal patient, it is ideal for doing biopsies. So it's a quick and easy way of approaching a lesion, if possible, and doing a fine needle or cord aspiration of the area of interest. And this could be done on an outpatient basis, with not much debility to the patient. The other thing we can assess with the ultrasound is, the size of the mass, if there's any surrounding adenopathy, any secondary signs like dilatation of the biliary tree or the pancreatic duct. And so that it's a good start. It's a good screening study to start off with. Endoscopic retrograde cholangiopancreatography, or ERCP, usually performed by performed by surgeons and or gastroenterologists. There's the odd radiologist that does it. Again, this is done with fluoroscopic controls, so we have like a movie X-ray that we're doing in conjunction with the gastroenterologist or the endoscopist, and they go through the stomach into the duodenum, and they inject contrast into the bile duct system and into the pancreatic duct. And due to if there's a tumor present in the pancreas, we'll see basically obstruction or deformity of the pancreatic duct system. And in conjunction with that, endoscopic ultrasound, which is a relatively new imaging focus, can be a little more specific in defining the tumor, the size and location, and also offers a possible biopsy potential. But then again, these are all performed by other than radiologists, although we do interpret the images. The next major development was multi-detector CT scanning. Now, CT scanning is based on the densities of various tissues in the body. So what it is with multi-detectors, we have multiple detectors in the gantry, and we have a fan-shaped X-ray beam that comes out. And so as the gantry rotates around the patient, we get various density representations through a single area. And we're scanning the patient, and what that does is it gives us higher definition, higher resolution, and a prettier picture. And with that, we can do various reformations and even 3D reformations, which the surgeons seem to like. Now, the advantages of CT is it's a very fast assessment. It can be done within minutes. And we have the option of contrast enhancement. And also with that, we can perform fine needle aspirations, another biopsy technique. And also it allows us to treat, distant metastases, like metastases in the liver. If they're in a suitable area, we can do something that's called tumor ablation, where it's basically we put a probe with CT guidance into an area in the liver or another organ, and if it's in a safe area, we can ablate it by using radio frequency ablation technique. Basically, we fry the metastasis, and this is useful. And the CT scan is also used for follow-up. When you come in, after treatment, we can assess if the tumor is the same size grown or if they're distant metastasis. Now, the common places for tumors to metastasize from the pancreas are, number one, they can spread contiguously and using just in the surrounding area. They can obstruct the pancreatic duct. They can obstruct the common bile duct, which causes jaundice, and it can give patients upper right quadrant pain. In the old days, commonly they would spread posteriorly because diagnosis was delayed and patients would have severe back pain. The other things we can do is we can detect lymph nodes or adenopathy. We can detect the tumor size and tumor extent in terms of metastatic deposits. Where are they? Are they above and below the diaphragm, or are there other collections elsewhere? And the other thing we see is peritoneal spreading. And this is from the tumor, basically tumor cells breaking off and floating down into the various peritoneal layers that we've described before, and seeding, taking up residence in these various areas. Usually CT is pretty accessible. Limitations are limited in terms of patient size. Doesn't seem to be too much of a problem, although it does degrade the X-ray beam and make some of the resolution a little bit fuzzy, shall we say. Contrast allergy is another issue, but it's quite rare nowadays. And most people have contrast injections without significant issues. If a patient does have an allergy, we can pre-medicate them with steroids. So as I said, basically CT is good for initial assessment, extent of disease, and possible treatment of metastases. And it's also excellent for follow-up assessment of the patient. Okay, next is MR. MR is also a fine tool. It's readily available, but it takes a longer time. And how does MR work? Well, you have to look at your body cells as being like little magnets. And what happens is that the system passes a magnetic wave or a magnetic pulse into your body, and then it shuts off and goes into a listening mode. So what the magnetic wave does is it changes the polarity of your body cells, and then in the listening mode, the polarity reverses back to normal, and sends off a signal, which the MR computers and algorithms solve, and it sends back an image. Now, healthy cells, they snap back in a normal fashion. However, abnormal cells don't, and that's how we define masses. And it's a very good, very accurate method. It does take time. It takes up to maybe 30, 40 minutes sometimes to scan a whole body. There are pathologies with MR. They're rare, but again, they're common. I should say they're uncommon, not that they're common. Something just crapped on my thing here. They're back. Oh, hang on, what happened here? There we go. Back again. So, MR is also a useful tool. It's an adjunct to CT scanning. And then that takes us on here to PET-CT. Now, PET-CT is a combination of both CT scanning and positron emission tomography. So what happens with PET scanning is it uses a low radiation emitting radionuclide contrast agent, which is basically sugar-based. And in conjunction, well, the tumors pick up this solution and emit a radiation focus, which is picked up with the radionuclide scanners, and it's also fused with the CT scan that's done at the same time. And it's very accurate. Again, it takes some time to do. It's very sensitive, but also not that specific, in that it can pick up tumor nodules and tumor masses. However, it also picks up infection. So, you may see things that you may think are tumor, but are not tumor. They may be just infected foci. So that's one of the drawbacks. So, but with CT and the study of the patient, we can do biopsies and what have you of very suspicious areas. So that's a general overview of what we do in imaging. From a diagnostic point of view, from a maintenance type point of view, we do provide central lines for patients. We do stenting and bypassing of biliary obstructions and things like that. Duodenal obstructions, we can stent those also. And those are all part of the follow-up with patients who have complications thereafter. So I'll take any questions. I try to make it as simple as possible. I'm sorry I don't have any images to show you, but if there's any questions, I'd be glad to answer them from an imaging point of view.
Yeah, thank you so much, Dr. Greco. That was great. I really liked how like you, I don't know, it really made sense this time. I feel like it doesn't always, so that was great. If there are any questions from the audience, feel free to unmute yourself or type your question in the chat.
Our imaging, I don't think, is going to offer you much more than what you're getting with CT. If your CT changes in any way, shape, or form, then maybe an MR may be indicated. As far as PET scanning goes, I think PET scanning is a good staging for patients that are going to be a surgical candidate. Okay, because it's very sensitive and it shows suspicious areas. And the only treatable lesion, the only treatable surgical treatment for this is basically a Whipple, which is a very difficult procedure and is really only suitable for patients with very small tumors located in the head of the pancreas. We're talking tumors of 5 millimeters or less, which is a quarter of a centimeter, or excuse me, a quarter of an inch. Those are not metrically familiar. So it's a difficult surgery. The recovery from it can be difficult, and it's the only ones those are the only type of lesions that are suitable, and those are usually discovered serendipitously when a patient's having a CT scan for some other reason, and then we find these lesions, and then these may be considered suitable for that type of surgery. So that's about it. If you're having good results with management with your CT scans and assessments, I don't think there's anything more to do, because I mean, the CT scan, you're there for what, 4 or 5 minutes? The scan's, quicker than waiting for it. And MR, you're going to be there for probably a minimum of a half an hour in the tunnel. So unless, there's something significant that changes with your condition, I think you're fine with CTs. Now, apparently there is genetic predisposition for it. I'm not familiar with the genetic testing that goes along with it, but I'm sure that there are various sites that you can look up on the internet, John Hopkins or the Cleveland Clinic or the Mayo Clinic or Harvard will all have sites that are accessible to you, and you can even get secondary opinions from them also. But there is a genetic link. There's also a link with obesity, diabetes, alcohol consumption. Now, how statistically relevant they are, I'm not sure, but there are links. That's interesting. I would trust the CT more because the ultrasound could be, obstructed by bowel gas or some other reason. Ultrasound is also very operator dependent. So, I mean, most operators are really, really good, but there are things that can change during the exam. A piece of bowel drip spine, they can obscure an area that you're looking at. So I think CT would be the gold standard. That's a good question. Right now, the algorithms we're using are sort of reduced radiation, and it's a balancing act. I mean, I figure a CT scan nowadays is equivalent to a plain chest X-ray in terms of radiation exposure. So, I mean, you're balancing off a significant severe disease with a long-term effect of radiation. I don't think, an adult really has to worry about that much. Even with children, I mean, we use low-dose radiation with them. So, and depending on where you live, sometimes the background radiation is higher than what you get from a CT. So where I live up in Sudbury, we have a high background radiation, but it's not equivalent to, CTs are not equivalent to that. So I think, pretty well off. I think considering if you have a certain type of disease, I think the risk management is worth it.
That's great. Are there any other questions? Okay, that's great. Well, thank you.
Is there anything that people want me to clarify on the talk?
Now's your chance.
I mean, PET scanning combined with CT is a very able method of assessing metastatic involvement. However, it is limited in terms of availability. Not everybody has a PET CT in their area. We're fortunate to have one up here. I mean, most of the major centers have them. Part of the issue with PET scanning is the radionuclide that we use has a half-life, and usually it comes from Hamilton. So, I mean, it has a half-life of maybe 8 hours. So, if we were to get it up here, our half-life would be maybe 4 hours of activity, which limits you to the use of it, in the scanner probably for about 4 hours of the day. So it's something that has to be planned. And as I said, it's only useful, I think, in my opinion, for areas that are in doubt and if a surgeon is planning to do significant surgery. There's no sense in opening a patient up if he's got disease elsewhere to do a Whipple or something like that.
All right, everyone. If there's no more questions, then we will give everyone back a little bit of time in their afternoon. Really, thank you so much, Dr. Greco. This was a great presentation, and I think it was really informative, and I know I definitely learned a lot. So, really appreciate your time today. Really appreciate everyone taking the time on their afternoon. I know this was an unusual time for our presentation, but really appreciate it. And yeah, with that said, hopefully everyone has a great day. If anyone needs anything, you can send an email to me, Erin at craigscause.ca. I can forward it along to Dr. Greco. And oh, I see Ben just put, don't forget the questions. There is a quiz after each module. So I'll be sending that around to everybody as well. So if you take the quiz, if you take all 10 modules and take all 10 quizzes, you're eligible to get a Craig's Cause sweater mailed to you. If you've missed any of the sessions, they are all recorded and you can go back in, and all of the quizzes are in the descriptions of the video. So again, we still are a little bit behind on some of the recordings, but they should all be up there very shortly. So thank you so much, everyone, again for taking the time today, and look forward to seeing you again. We'll have our next presentation on palliative care and versus end of life care, and that'll be December 19th at noon. So I'll send more information about that as well.